Executive Director with SMI, and I'll be your host for today's webinar session. Before I introduce our presenters, I'd like to review a few housekeeping items. First, all attendees are placed on mute. We have found that this is the ideal method to provide clear audio for everyone, but we do want you to submit your questions, so please use the questions feature of the webinar technology to submit any questions. All questions will come to me as the host, and at the end of today's presentation, I will read the questions and our presenters will do their best to answer them. Secondly, we are planning on a 60-minute session today, but we may run over based on the number of questions. We'll see how that goes, so we appreciate everyone's flexibility. And finally, SMI will be administering a brief survey following today's session. We appreciate you taking a few minutes to answer that survey, as it helps us to continue to work on improving our program. Now it's my pleasure to introduce our presenters today. We have three presenters. The first is Mr. Rhett Suri. Rhett has been employed by Abbott Labs for 27 years in sales, training, contracting, business excellence, and most recently as the Director of Healthcare Credentialing for Abbott. In his current role, Rhett is responsible for directing an efficient and effective credentialing process for Abbott, spanning multiple business segments and approximately 4,000 impacted employees. Brett also serves as the chair of the AdvaMed Legal Committee, HCIR Credentialing Working Group, and the chair of the Consortium for Universal Healthcare Credentialing. In these roles, Brett works to collaborate with all stakeholders on best practice solutions, written and data standards, and an interoperable process for credentialing requirements. Brett is being joined today by J.P. Isom, Supply Chain Manager of Operations and Logistics at Christus Health. J.P. has over 18 years of experience. In his current role, he supports all Christus Health facilities in various logistics and operations management initiatives, ranging from inventory management and process improvement, transportation, etc., to interim roles in materials management. He's also responsible for managing the relationship between Christus Health and VendorMate, the designated third-party credentialing organization that they utilize. Our third presenter is Ms. Heidi Retzlaff. Heidi is the global leader, in the Global Labor and Employment Council for GE Healthcare, based outside Milwaukee, Wisconsin. Heidi started with GE Healthcare in May of 2003 as U.S. Labor and Employment Counsel and took her current role in 2013. She supports various business units within GE Healthcare in the United States, and in this role she is responsible for global labor and employment strategy and compliance for GE Healthcare's 54,000 employees. She has been involved in vendor credentialing issues for GE Healthcare since 2004. SMI has been a strong supporter of standardized and streamlined vendor credentialing since the earliest days, and we are pleased to continue that support by hosting today's webinar. With that, let me turn it over to the Consortium's team. Rhett, take it away.
Well, thank you, everybody, for joining. I appreciate the introductions and the kind words, Dennis. We are going to take turns going through these slides and answer any questions that you may have at the end of it, but again, I appreciate everybody's support. And I think the next slide is for JP.
Yes, and to echo Dennis and Ray, thank you everyone for joining the webinar, and hopefully you will gain something and any insight regarding credentialing. And please allow me to read the slides so everybody's on the same page and there is no deviation. And it's related to the mission of the Consortium. The mission of the Consortium for Universal Healthcare is to streamline the healthcare industry representative credentialing process in a manner that will protect patient safety and confidentiality, eliminate duplicative effort and cost, and meet the needs for both suppliers and healthcare providers. The Consortium looks to accomplish this goal by solidifying written data standards for credentialing, promoting adoption of such standards, and creating an interoperable process to communicate those standards. That's the mission. Thank you, Ray.
So as far as the consortium and who's involved, our goal is to try to engage all of the stakeholders. The two primary stakeholders that are involved in the credentialing process are the supplier organizations and the provider organizations, because they are the two parties that are responsible and accountable for ensuring that all laws, regulations, guidelines, and processes are met. So we have an updated list of all of our supporters and supplier members on our website, which we're going to reference later. But this gives you an idea of the diversity of the participants in the consortium activities. The providers have an opportunity to support at different levels. One is just a general support of the mission of the consortium, which JP just read. And then if they have the ability to engage in a little bit more detail and participate in some of the working groups of the consortium, we have an agreement that we can sign that outlines what the responsibilities are for each party. We do have others that participate because we certainly want to get the opinions of as many stakeholders as possible whenever we have that opportunity. So again, providers and association members and supplier members, I will not read through that at this point. So next slide. So some quick facts. I think some people probably are aware of this, others may not be. But the first quick fact is that credentialing adds over $1.7 billion per year to supply chain costs annually. Most of this is not value add. It's duplicative labor, which in the supply chain world everybody kind of defines as waste. If it's more work without incremental value, it's classified into the waste, and that's a focus for everybody probably on this call, is eliminating waste. The next fact is there's up to 20% inaccurate data in the current systems. That's an estimate. We're in the process of doing a more robust survey to quantify exactly where the gaps are and how we can address those. One of our primary goals for the consortium is to ensure that we're providing accurate and timely information for the credentialing requirements. We're going to be talking a little bit later about technology and how that could impact costs, etc. One of the things we need to bear in mind is technology can be a great thing for us, or it can be a bad thing. With the technology that's available today, there's a potential for an explosion of solutions because of apps and cloud-based computing. If we don't have standards, that's going to make those numbers much larger as far as the duplicative efforts. But with standards, we can leverage that technology and get the information to the parties that need that information more accurately and more timely. As I mentioned, we're doing a survey because currently there are no metrics to demonstrate that credentialing has had a material impact on patient safety or patient confidentiality. There are anecdotal stories about situations where there has been an impact, positive or negative. We are starting to see, because of the duplicative nature of credentialing and some of the inaccuracies, that we could potentially be creating more challenges for patient safety and patient confidentiality. So all that to say, what are we going to do about it? So we're going to talk a little bit today about a potential better way and what the consortium is focused on. So we'll turn it over to Heidi for the next slide.
Thanks, Rhett, and I want to add my thanks to everyone for joining today. As Dennis said, I got my first question about vendor credentialing sometime in early 2004 and have seen it just steadily increase and explode over the years. SMI was at the forefront of trying to address the issue with a white paper in 2006, which lays out some great ideas for standardizing processes, not only with the credentialing process, but access at the sites. In 2009, AdvaMed led an initiative where we tried to work to have the Joint Commission issue standards so that we could have, consistency. The Joint Commission declined and said we don't really play in this space, and we've seen, unfortunately, that that's not necessarily consistently held. So we're going to keep working with them to try and clarify. We've seen legislation in several states and Veterans Affairs. There's pending legislation now in Congress to get standards for the VA. The only two that are still pending are the VA legislation and New Jersey state legislation. all of them have advocated, other than the New Jersey pending bill right now, have advocated for national standards, which we think is really important to help our businesses and our provider, clients who work across many state lines. So in 2012, the Coalition for Best Practices in Healthcare Credentialing formed to promote and share best practices and advocate for national standards. And Rhett was leading that as well and was doing a great job, but we just weren't getting the traction. So in fact, instead of seeing kind of adoption of standards, we saw more proliferation of new and different standards as many providers decided on specific things that make sense in their context, certainly, but make it very difficult for all of the suppliers to comply. So we started the consortium then last year. And I'm going to turn it over now to JP to talk about, why as a provider you should really care about this.
Thank you, Heidi. And yes, as you mentioned, why as providers should care about the work of the consortium specifically, and in some extent the work of credentialing. We have so many reasons, and I have some of them. The first one, I will talk about, we as provider, we care about the privacy and confidentiality of our patients. Okay, so to resolve this issue, we want the consortium to give us, or to be a focal point where we can get and assemble correct and accurate data. Next, please. And the second reason why we care is because of security concerns. We want people visiting our facilities to be in good standing with the laws and to be good people. So we don't want people on the sex offender list or registry to visit our facilities easily. And we try to protect our employees and our patients with identity theft and gun control, the whole 9 yards. So we want a safe environment for our employees and patients. And the third one is health concerns. As you know, we don't want reps visiting our facilities to have healthcare issues such as TB and flu and everything else. We want them to be up to date with their shots. Next, please. And we like to use credentialing and the work that Consortium is doing to streamline access to our facilities. By that, what I mean, we want to monitor any reps coming to our facilities. Specific to Christus, our supply chain, our procurement is centralized. We try to limit reps' visit to our hospital. So we use the data that you guys work with to make sure that reps are not unnecessarily visiting our facilities. Next, please. And yes, today in today's environment, I would tell you, and you guys probably know, we have at least 3 VCOs. And let me tell you, all 3 of them talk to me all the time, but it's hard for me to differentiate. There is no competitive advantage from one to the other. So I don't know if VCO 1 is better than VCO 2 or vice versa. So there is a little bit of confusion, or they do the same thing. So there is no competitive advantage one to the other, which can be not good for us. Okay. And as a Christus, we care about our vendors. So we want the relationship between the vendors and us to be a win-win relationship. So we know that you guys are paying a lot of money to go through credentialing. So that's why we decided to support the work of the consortium. As Red mentioned earlier, you guys as vendors, you spend about $1.7 billion just on credentialing, which is, and most of the $1.7 billion is not even value added and very expensive to you. And somewhat we know that you guys, the cost trickles down to us. So we try to make sure that you as vendors, you guys as suppliers, reduce the cost of vendor credentialing with accurate data, one source, like one point source, So yeah, as you can see in the slide, it costs about $299 for a high-profile vendor to register in our current VCO, which is expensive when you got to do it over and over and over. So we are here as a provider to support your work. And last but not least, I want to talk about compliance. Yes, we are today, Christus, using a third-party VCO. However, out of 9,000, close to 10,000 active vendors, only about 2,600 are registered to our vendor credentialing company, which is, you can do the math, the ratio is not good. Thank you very much. So those are some of the reasons. Next slide.
So from a supplier perspective, GE Healthcare is involved because we, like most responsible suppliers, have had background checks and other ways to confirm that our employees are safe and do their jobs well and know about patient confidentiality and safety. We have those in place because we think they're important, and that vendor credentialing is not going to change that for us. We also have standardized source data in our system. So we know when people have done background checks, we know when we've done this training, et cetera, but it's all in different, you know, we have a learning system, we have our hiring system, et cetera. So, but we have all that data. The problem for us is that we'd like to try and address through the consortium is that we have that data and we have ways to pull it, but we're being asked to pull it in many different ways for many different vendors and or providers. It's not clear that having it in a certain format, you know, aids in the accuracy of the data. In fact, we think the more we have to pull it and put it in different formats, et cetera, probably the less accurate that the data is. And in addition, we are seeing a lot of duplicative efforts. So things like customers that want a background check within 60 days of when the person comes on their site. We have, you know, employees that go to many, many different provider sites, and so as those change or they try a new one, we could conceivably be getting into having to background check employees every couple months, every 6 months, and I'm not sure how much more that provides to us. Or we might have to provide a Social Security check or a drug screen on someone that has been our employee with no problem and had those checks in the past. So we're looking to really try and avoid some of the duplicative efforts so we can spend more time. Because when we talk about cost, I think JP is totally accurate in we spend a lot of money on different things like background checks and VCO registrations, et cetera. We spend a lot of time trying to get the data right for all of our different providers, but that's a lot of our employees' time too, and that's what I think would be the best save for us, is making sure that our employees, especially those that are out trying to service, you know, imaging equipment, et cetera, wouldn't have to spend as much time on duplicative or differing requests. So I'm going to turn over to Rhett now.
So I'm a big fan of visuals, so we thought we'd take some of the points that are made and kind of put it into a visual. And the one example that we're going to use through most of the visuals is related to the background checks, because that is one of the more challenging ones. It involves sensitive private and personal information on individuals, etc. So it's a good example. So kind of current state today, an individual may be required to have multiple background checks. Certainly they're having at least 2 background checks performed, and some can have as many as 4 or 5 background checks performed. So that individual or the company that is doing it on behalf of their individuals is, you know, spending the money, spending the time, and incurring a certain level of risk because of the sensitivity of the information that's being provided to do the background checks. So in this example, we're just highlighting 2. So you have a background check A and a background check B. The work, and Heidi alluded to this, doesn't stop there. We now then have to take that and put it in multiple different forms. So it may be the same background check, but somebody's requiring, you know, an attestation in this manner or with this wording, and somebody else is requesting an attestation in a different format or on a different form. So I use colors to represent, you know, blue paper, purple paper. It's illustrative of the challenges. So even after we've done those duplicative background checks, then there's further duplication in how you document it. So the next slide, and this is actually the person that's, a very important point, sorry Dennis, and I didn't realize this, I guess, until I really started talking to the background check providers and understanding the nitty-gritty details on background checks. If you do it properly, which is what we're advocating for and what most responsible companies already do, all the information is from the same source data. It's not like somebody's going to do a background check, go to the county courthouse, pull the file folder, and find different information. It's all the same source data. This National Sex Offenders Registry check is the same source data. So again, if we have vetted that employee using the source data and have that information in our systems, we should be able to utilize that because there's no incremental value with duplicative background checks. So now next slide, Dennis, sorry about that. So again, back to that cost without value equals waste. And what's happening is we're spending 99% of our time on the quote-unquote good guys and 1% of our time on the bad guys. So our goal should be to streamline the process for the 99% of the reps that don't have any flags, there's no history, they flow right through. And then if we have somebody that has some kind of a flag, then we spend our time and effort on that to understand, does that person really create any kind of a risk to their employer or to our customers where they're going to be working with them. So kind of shifting the focus here a little bit. Next slide, Dennis. So the consortium was mentioned. We put out a best practices document in 2012. And that best practice document says the responsible and accountable party, typically the employer, is responsible for ensuring that a background check was done to a high standard. And again, there's some time and money involved with that, but half as much as if you have to do two of them. Then we take that information, we put it in the form of an attestation that the background check has been done, and then that attestation letter can be accepted by the various provider organizations or third-party companies that are looking for or serving as the agent to the hospital. As a side note, this is the model that they're currently using in Canada, where the suppliers attest that all the requirements have been made, providers sign up and say, we'll agree to that attestation. We believe that they've done it to a high standard, and that's about as far as it goes. Okay. What the consortium is looking at, next slide please, is why don't we take that even further? And those that are involved in SMI know that there's a lot of work done on data standards, predominantly GS1 standards with GLNs and G10s. So why can't we do that with the information related to credentialing? So once the responsible and accountable party, the employer, gets the background check report, can we distill that down to the data elements or data standards to communicate that that background check had been performed at a high level, and then have that information easily and readily available to all the parties that need it? So if you're familiar with GLNs, that middle number there, there is a GS1 standard out there that we could leverage to create a unique identifier for a representative. And then what we've discussed thus far is for that industry standard background check, the only information that really should be necessary to convey is the date that that background check had been done. So this unique identifier in that data element would go out to a data repository, and from there the providers could access that directly or through one of their agents, their third-party companies that they're working with. So it's important, and we're not going to get into a detailed discussion about this, but this is now validated data, and there is the ability to audit that information should somebody need to do that. You've got a unique identifier and a date. That information flow can be audited back to the source data to confirm that that, in fact, has occurred. It's something we've talked about. I always want to put the little note in here that that doesn't happen today. So we want to ensure that we have accurate, up-to-date information that can be audited, understand that that information is not audited today. Okay. Next slide, please, and I think it's over to Heidi. So do we have to do this right away, Heidi?
No, because that will take a little bit of time, all that great interoperability and standards, et cetera. We do have a template for consortium members to use. that puts all of the data into a standard template, which is easier, we think, for providers because it will become a standard that they see, as well as for the suppliers. And these are based on the healthcare best practices. And we are, one of the, I think, benefits of membership that we'll talk about before or supporting the consortium is we do seek input from others on what are the right standards, how should it all work so that it can work seamlessly for everyone at the end of the day. So you'll probably start seeing, if you're a provider, you might start seeing some of us using this template. It can vary. There's additional information that might be on it that doesn't fit on the slide, but depends. So if you ask for certain information, we can provide that certain information. If there's more requests, we have a template to provide more of that as well. Next slide, Dennis, please. So is there a better way? We think so, like, Rhett's going to provide a little more detail about that, but some of the guiding principles that we're thinking about as we think about that better way are making sure that we allow current relationships to remain intact. We aren't looking for a proprietary solution. We aren't looking to cut anyone out of the process. We're just looking for a way to make it easier for everybody to get the right kind of data that they need to feel comfortable that supplier employees that are coming on site don't present risk to their employees. So we're not looking for a proprietary solution. We do need to make sure that we can address the accuracy gaps. As Rhett noted, there is no auditing now. We don't know how accurate the data is. We can tell ourselves that there are gaps, and as Rhett said earlier, we're looking to try and quantify that again. We want to make sure that we eliminate duplicative work that doesn't bring value. So again, that doesn't bring value is the important piece. We want to make sure that we address requirements that are not appropriate or create data privacy concerns. So for instance, just like providers have concerns about the privacy of their employee data, we have concerns about the privacy of our employee data. And when a provider is asking for something, do they really need the source data? Can we confirm it in order to better protect the privacy of our employees? We also need to address some of the complexity in the system, right? Various different requests, requirements, formats, et cetera. And we need to be able to gather metrics to measure and improve. The purpose would be to make sure that it supports all of our goals while being easier, more cost effective, and accurate for everyone involved. And as the asterisk notes, none of this is part of the current kind of ad hoc systems that we all see. I'm going to turn it back now to Rhett.
Thanks, Heidi. So one of the first things that we have to have in order to be able to accomplish standardization and interoperability are data standards. It's obviously a lot easier to verify and transmit data, and it's certainly a lot easier to have interoperability if you have data versus documents. So this is just a snapshot of some of the data elements that we're looking at. We've broken down the reps requirements into administrative requirements, training requirements, and medical surveillance requirements. So we have looked at all of the different requirements that we've had from all of our providers and third-party organizations, and we've compiled a very comprehensive list of what we think needs to be in there. It may look initially like a lot of work, but if we can establish this target, establish what those data elements are and the data standards are, then each of the suppliers can work internally to have that data flow out of their existing systems that Heidi mentioned, that is validated systems and they're up to date, and have that data flow out to the data registry. So long term, it eliminates a lot of duplicative labor. It ensures the accuracy of the information, and the information is coming from as close to the source data as possible. Next slide, please. And then here's a very messy schematic of what that might look like. On the left-hand side, we have, the representative and the employer that can provide information, again, using the data standards, either to a vendor credentialing organization or an agent of theirs, or directly to a data repository, and everybody's going to have a different view on how that is done. Once it's in the data repository, then it's available to all parties that need that information, vendor credentialing organizations, other third-party agents, or directly to the facilities themselves. In the upper left-hand corner, I pulled out a specific agent to kind of give an example. So each of us has a contract with a background screening company that does all the background screening on our employees. What we would do is work with our agent for the background screening to ensure that they are doing the background check to the standard that we establish, the written standards, and then they may be the ones that could transmit that unique identifier and the date to the data repository. Or suppliers may decide they want to have that information in their systems, and then they push it out to the VCOs or to the data repository. The beauty of all of this is it's data. Once we have it in data, you just set up, and this is beyond my area of expertise, but people that know how to do this can do it fairly rapidly. You set up the information flow, it gets there, nobody needs to touch it, nobody can modify the information, so the accuracy and the timeliness of the information is going to go up dramatically. I also put up in the upper right-hand corner, we're seeing more and more requests for company-level information, driven largely by the OIG guidance document in 2013, I believe. That information is largely public and static. So the consortium is looking to create data standards on company-level information, such as the tax identification number, the doing business as, remit to addresses, etc., and push that information out to the data repository as well. Everybody has that information. Finding it will take a little bit of work, but there are people within each company that know what that information and can provide it accurately. The sales rep is not the best source of information for company-level data. And then on the right-hand side, again, once we have it in data, then we can leverage all the technology solutions that are out there. And the technology of today is very different than back in 2004 when Heidi was first asked about credentialing. There's clouds, there's apps, there's smartphones, there's fingerprint ID pads. There's all kinds of mechanisms to be able to verify that that person has met the requirements by querying back to the source data either directly or indirectly through third-party companies. We can do QR codes. So the possibilities are endless, and that's one of the things that the consortium did a little bit of research on back in November. So I put my little disclaimer in there that there's really not any company's name there other than Abbott, but it's something that we're not going to force proprietary relationships like Heidi said. We want to make this accessible to all parties. Okay, next slide, and I think it's back to JP.
Yes, sir. Thank you. And in this slide here, I will briefly talk about the benefits from a provider perspective to join the consortium. Yes, as you probably know, the first benefit is we want our vendors to come up with a very good, reliable solution to vendor credentialing. As you all know, vendor credentialing been an issue for years and years, and you heard it here and you heard it in other conversations. And we want to be part of a solution that will provide accurate and up-to-date data from a primary source. I already talked about it, Ray talked about it. That primary source is a very good thing for us, and we don't want to go all over the place, or we don't want to have data coming from all over the place to a third party. So if we can be sure and confident that the data is coming from one primary source, that will be a great win for us as providers. And the second one is a universal standard for processing data, document to promote consistency. As you know, anything consistent is reliable. So if you have too many variables, that's not good. And that's the issue that we're facing today with data coming from different from different perspectives and different ways. Okay, so that's one of the things. And vendor accountability. Yes, vendor accountability to the employees. We want you guys, if this consortium work goes all the way to the end, accountability of the vendor will go back to you guys as vendors. So that's a big win for us as providers. Of course, elimination of waste in credentialing process. Waste is not good in any process. So based on the work that the consortium is doing beyond the scene, if we can eliminate waste in the process, that would be a big win. Time spent addressing different concerns and for vendors, that's another thing. It's almost the same as eliminating waste. Verify data, and I will end up by saying promote increased compliance and decrease risk. Risk is a big thing for us. As we mentioned before, with patient safety and patient confidentiality, we don't want to increase no risk. By the work that the consortium is doing, we are, as Christos, we are confident that we can eliminate compliance and decrease risk for different stakeholders. Thank you.
So I'm going to talk now about the benefits for a supplier joining the consortium, and it really is the opportunity to provide input into the right solution. And we think that solution is going to ensure accuracy of data. It's going to give us as suppliers control over our data so that we can update them. We can, more easily when employees leave, make sure our providers know that very quickly so that they can't, still hold themselves out as an employee of ours. We think that the universal standards and the data standards will allow us to simplify our processes and make sure that we can respond to customers really in real time. As soon as we get a new customer or if someone wants to go to a new site, they'll be credentialed. And by joining the consortium, you are able to use the consortium logo, which holds yourself out to suppliers as someone that follows these standards, understands what is expected, and thus is following best practices. So we'll be able to better protect our employee privacy, which we talked about earlier as an important thing. I think that providers and suppliers can understand why that's important. And then we will eliminate duplicative efforts, or the solution will eliminate duplicative efforts. And we would love to hear from more of you about what you think about the standards and how they would work for you, and your ideas about what makes most sense so that, again, as we said before, we can reach a solution that benefits all. JP?
Thank you. Yes,
yeah,
go ahead.
I think this one was me.
Go ahead, sir.
Sorry.
All right. So what does this look like? What is the time frame? So we tried to outline some deliverables here. Some of them have already occurred. We had our first board meeting of the consortium on June 3rd of this past year. So again, a lot of the work of the consortium is based on the prior work of the coalition and SMI and some work that was done in Indiana and Mayo Clinic. So we built upon the work that had been done, where we think that the biggest difference is we're actually looking at a way to operationalize the standards that have been recommended for some time. We, as Heidi mentioned, we have a logo. We issued a press release, and we launched our website in August of 2016. There's lots of great information out there, and we plan to keep updating it, so we encourage you to go out there. In September of 2016, we approved the data elements. So it was that chart that I showed earlier saying a background check, we think that we should be able to use a date. If we get into medical testing, can we do a red light, green light so that we're not, potentially violating HIPAA high-tech laws? So we finalized the data elements, and that went out into our RFI back in November of 2016, which we distributed via website and directly to the current vendor credentialing organizations, the larger vendor credentialing organizations. Our intent there was to get a better idea of what technology was out there and what potential solutions there were. Again, we're not trying to create a proprietary solution. We're trying to figure out what the best solution is. And then we started receiving letters of support for the consortium from various organizations, health systems, individual health systems, professional organizations like AORN, who is the Association of Perioperative Nurses. They've been involved in credentialing since the very beginning as well. It's interesting to note that their guidance document for vendor representatives in the operating room references the best practices document that the consortium holds. So that's kind of what's been done thus far. Next page, please. Actually, there's a couple more things. We had our second board meeting in December with the presentations from some technology solutions providers, and we began a baseline study for our current state to highlight some of the challenges that might exist with duplicative and non-standardized credentialing. So what we're in the process of doing today is we're beginning the certification process for data standards. So in order to create that interoperability, we have to have very specific details around the data elements and the data standards. And the easiest example is to say, is it day, month, year, or month, day, year? Those are the types of things that need to be, hammered out and detailed in certified standards, so that when we are building our internal systems, or the providers are building their systems to receive it, or the third-party agents are figuring out how to manage this data, they can look at this document and determine exactly what needs to be done. And again, I'm not an expert on it, but we have a couple experts that participate in those calls, and to them, it's not that difficult. There are standards around data transmission that have existed for a number of years. We would just use those standards to define our data elements. So we're also launching standard templates for the attestation letter, which Heidi referenced, and I want to spend just a little bit of time talking about the code of conduct and the orientation document. One of the things that is very challenging is managing all of the policy documents that each representative in each company has to review and agree to. For the most part, they all say exactly the same thing. Every code of conduct says exactly the same thing. So what we're proposing is that we can distill that down to a vendor code of conduct that says that the individual will comply with all applicable laws, regulations, guidelines. That's stuff that the suppliers have to do anyway, because we operate in the same highly regulated environment that the providers do. The second piece of documentation that we have already created is an orientation document. This would be the specifics about how that individual should operate once they are on premises of the healthcare provider. So it's the park here, check in here, here's the GPO we're affiliated with, here are purchase terms and conditions, here are the safety codes of the hospital, but it would be in a template and have just kind of the most basic pieces of information that are critical for the representatives to know. Right now, there's 5-page documents that are really geared towards hospital employees, not towards the vendor reps, but there's one paragraph in there that's specific to the vendor representative. So we've actually compiled a lot of those policies and some of the best practices language and already populated an orientation document as an example. But we think that that information then could easily be shared with all the parties that need to do it. It's also easy to update. I review every policy that our reps are being asked to sign, and some of them are very outdated and reference organizations that don't even exist anymore. So I think it would help with revision control and accuracy of that information as well. So one last comment on that. Mayo Clinic back in 2012, when we came out with the best practices document, they redacted out the most important pieces of their policies, and they went from, it was over 200 pages of policies down to, it was either a 4- or 5-page document. They've been utilizing that now since 2012, and they have not seen any adverse effects of redacting it down to the most important pieces. So, some good information there. Bear with me a second. My screen went to sleep, which tells me I've been talking too long. In Q3, we are planning on beginning the pilot program with data standards and a national data registry. One of our members graciously already has created the pilot data repository with those data elements that we outlined earlier. Obviously, we haven't gotten all the details as far as the standards there, but it's a working model, and we're going to begin populating that in a pilot program in the third quarter of this year, maybe sooner. In the fourth quarter, we want to conclude the pilot program. We're going to gather some data, some facts and metrics, assess what worked and what didn't work, refine it, and then put an RFP out for the various solutions that could work in the industry. And then our goal is in the first half of 2018 to have a scalable solution with data standards and interoperability. It's important to note that we know that everybody is going to desire to align to and be able to align to data standards and interoperability over a period of time. So again, that's why we're not trying to force a solution. Once we have those targets, though, people can start designing their internal systems and processes to be able to generate those data elements so that they can get into the interoperable solution. The sooner somebody does it, obviously, the quicker they can take advantage of eliminating all the waste and increasing the accuracy, but there's not going to be a specific deadline for implementation. Okay. So with that, next slide, I think it's JP.
Okay, the ask here is for the suppliers to join and for the providers to support the mission of the consortium. And you can do it by, you have a link here for the contact. You can go to the website and you will get more information. Or you can reach out to Red, Heidi, or myself, and we will guide you on how to join the consortium. And participate in working groups of the consortium. Okay, we need your input. Standard, technology, advisory, and advocacy. And our standards are created to agree to accept document and data. So the bigger the group is, the better solution we will come up with. So keep that in mind. And as technology solutions are developed, integrate those solutions into our current credentialing processes. And last but not least, help us identify elements that we have not thought of. Okay, anything that the consortium, as of now, is still limited to a few members, but anything that we so far didn't think about, you guys can, anybody who wants to join the team can bring. So we really need your input and your participation. That's our ask. Thank you.
With that, Dennis, I guess if there's any questions from the group.
Yeah, Rhett and JP, thank you all very much. Thank you, Heidi. You did receive a number of questions, and as I could have predicted, the very first question was, can we distribute copies of these slides to the attendees of today's webinar? That's perfectly fine with me. We'll probably also post it on the consortium website, but yes, feel free. Great. Great. This is Dennis Orthman. I will make sure that I mail those out to the email addresses of everybody who's been on the webinar today. Number of questions also came in during the course of the webinar, and one of them came in when one of the slides was talking about the inaccurate data that was in the system, and the question was, what can we do now to improve the inaccurate data that you said is in many of the systems?
I can address that and see if JP and Heidi have any other input. It's honestly a challenge. The supplier community does not necessarily have visibility to all of the information that is in the various systems, whether it's provider or supplier. The representatives themselves are providing that information, and I think I used the example like a company tax ID code. Representatives may not necessarily know what the company ID code is, and sometimes they'll put either their division level tax ID code, or in some cases they've given their own personal social security number. So the challenge is we don't have visibility to that information, or there's a cost associated with having visibility to that information, so it's difficult to reconcile. That being said, I think the suppliers can ensure that they have a process that their employees are aware of to provide that information. And I know that there's various levels within the supplier organizations in getting that information or a standardized process for their employees. Again, part of the reason is it's a moving target. The suppliers don't know what information is going to be asked for and in what format, so finding a place for that to reside is a challenge. Again, that's one of the benefits we think once we establish the target, they can go after that. But the suppliers can begin thinking about how they can centralize the process, standardize the responses, and then provide that with a level of oversight to the third-party companies and to the providers themselves.
Hey, Dennis?
Yes.
Yeah, in addition to what Ray just mentioned from a supplier perspective, from a provider perspective, I will tell you, talking about my organization, Christos Health, we are at the mercy of our third party. So we cannot validate the accuracy of the data that we receive. So we rely on another organization to vet the accuracy of the data. So that's where we at, yes.
Okay.
Hey, Pete, you brought up a point that I want to stress here, though. The last thing the suppliers want to see is a draconian approach to validating the information now. We are responsible and accountable for our representatives' information, and that's why we're proposing that we create standards that we can provide validated data. The last thing we want to see is, 20 teams of inspectors coming in to do audits of our systems and processes. That's only going to further drive costs up, and it's not going to solve the problem. So I just want to make sure we understand the importance of accurate data, and that's why we're proposing that we create data standards in an interoperable process, but we, as the employer, are the ones that are ultimately responsible and accountable for that. Hope that makes sense. And Heidi, that may fall into a little bit of your area of expertise if you have any follow-up comments.
I don't.
Okay. I got a great question here. I don't know if you want to answer it or not, but one of our webinar participants asked, what does the consortium think of the current offerings in the marketplace, like RepTrax and others?
I'll try to address that. I think individually, they're fine. In aggregate, that's where we run into problems because, individual solutions probably work. Even at a specific provider site, the providers may feel that that solution works well for them, but when you aggregate that up to the entire healthcare industry, that's where we run into challenges. And too much of our time is being focused on getting our rep the 12th version of bloodborne pathogens safety training and not being able to address, hey, somebody really is outdated on, their tuberculosis screen or something. So individually, no issues. In aggregate, it's a problem. Again, getting back to the theme of standardization and interoperability.
Okay. Here's another question. So how do you get the credentialing companies to follow state standards instead of national standards? And they go on to comment that the CDC requires TB tests every year, but Pennsylvania requires them every 2 years. That's an example of state versus CDC.
Yeah, there are going to be some minor state-by-state variations, but I think we need to back up a little bit, and this is hopefully one of the goals of the consortium. A lot of the requirements or stated requirements out there are not really applicable to vendor representatives in the healthcare setting. There's a lot of misinformation, misrepresentation about what is and is not applicable to representatives. I'll give a quick recent example. We're seeing an increase in requirements for the suppliers to say or to agree that they've done all the CMS training, Medicare, Medicaid fraud, et cetera, because we are quote-unquote downstream entities. The majority of the suppliers involved in credentialing are not, by definition, downstream entities. So the first thing we need to do is look at the requirements and determine, is that really, are representatives really within scope of that requirement? And we've done a lot of work on this already, and the vast majority of them are that we are not within scope. It is going to be the hospital policy that dictates what the rep has to do, and that's where clearing this up is important. Everybody keeps saying Joint Commission requires all of these things for vendor credentialing. That's simply not true. The Joint Commission will survey to what the hospital policy is. It does not say that the rep has to do all of these things, but if you put it in your policy, then they're going to survey to that. So you have to be careful that you don't create, you know, an opportunity for non-compliance by making your requirements overly stringent. That being said, we want to make sure that we're doing all the things that are applicable for our representatives.
That's a good point, Brett. Brett, we've got another question here, and it's about the size of companies and large companies versus small companies. Is there a plan to help make sure that all size companies can afford this? Because some of the smaller companies don't have the bandwidth or the resources to really implement it.
Yep, absolutely. Again, why, and let me back up. There was a lot of discussion before the formation of the consortium about, okay, we've been talking about this for 10 years. How do we fix it? What does the solution look like? What is the vision of success? And the data standards and interoperability were a key piece of it, and one of the main reasons were for the small companies or the independent representatives. They may not have the resources of a large company, but then they can contract with an agent or a third-party company to be the aggregator and distiller of the information down to those data elements to push it out to the repository. So the system is open and accessible to everybody. Our initial discussions are that this is going to be kind of a per rep basis. The burden is going to be based on a per rep basis, but it should be substantially less than what it is today, just because we're going to eliminate all that duplicative labor. If we only have to do it once, or a small supplier only has to do it once, or an independent rep only has to do it once, we're going to drive cost and waste out of the system.
Thanks, Red. Got a couple more questions. We're just about running out of time. Excellent question here. Do other industries have vendor credentialing like healthcare? And if there are, do they use them effectively?
So I maybe can answer that, Brett, and others. In GE, we have multiple different business lines, obviously, and I have heard that several of our other businesses are getting requests like this in the oil and gas industry, the power industry, and I think our energy connections business. It is not, though, anywhere near to the level of what we're asked to. And the other thing is those industries usually, will send someone to a few customers, not the vast number that many of our, in the healthcare industry, our employees go to. So we can't learn from them. We, in fact, have been a bit of a best practice sharing for our colleagues in those other GE businesses.
Great. Thank you, Heidi. I've got one final question here. Prior to the consortium's database, they want to know how can they challenge background checks that are not conducted by the employer?
There's some documents, and this again is part of the value of being a member of the consortium. We have some responses that have been drafted by the appropriate people and legal overview that points out some of the potential challenges around that from a privacy standpoint, from an FCRA standpoint, and highlighting that there's really no incremental value. It's already been done. So we are currently working with a national association that is involved in background screening to try to help us better define the industry background check and have a means of communicating compliance to a standard so that we can provide assurances to the providers that that background check's already been done, and it's been done to a high standard. In many instances, the vendor representative has had a more recent or more thorough background check than even the employees of the providers themselves. Not in all cases, but in some cases. We just need to figure out how to communicate that effectively so that the assurances are there and people are comfortable with it. But short term, reach out to me. I'm happy to discuss that with you. And like I said, that's one of the values of being a consortium member is we collaborate on this. We find out who is a subject matter expert on it. We put together responses, and then we share those responses.
That's great. It's great. Well, Rhett and Heidi and JP, thank you very much for this wealth of information here. We've had over 50 registered sites tuned into this webinar today, and each site could be one person or it could be 20 people in a conference room. So we thank everyone for participating today. I will be sending out the slides that we've used to all attendees, and included in that will be contact information for our presenters if you have any further questions. I will remind everyone that there is a brief survey administered by SMI following this webinar, and we appreciate if you take the opportunity to fill that out. So with that, we're going to adjourn today's session. And again, my thanks to our presenters from the Consortium for Universal Healthcare Credentialing, JP Isom, Heidi Ratzliff, and Rhett Surrey. Thanks, everyone. Have a great day.